All right, guys, here's the respiratory lecture as requested. Starting with a couple of review questions, quick. First is immunotherapy review. You guys can go through these actually, and we'll talk about them since we're doing a review session. I'll go through them during the actual session on Monday. Okay, so let's get to inhalers. There's three major types of inhalers. I say two types on here because soft mist and metered dose are technically kind of in the same family. Dry powder is a different one. So there are two major types, but the soft mist inhalers are kind of a newer form. They aren't real popular. Mostly you're going to be looking at metered dose, which also sometimes get branded as HFA, which I think stands for high flow or something like that. Either way, it doesn't really matter. You'll see MDI or metered dose inhalers out there, or dry powder are the big ones. I don't think inhalers I guess what I'm trying to say is that common sense doesn't really apply to using an inhaler. I think that they can be a little non-intuitive to use, not as easy as people think, which can lead to adherence issues. And I think education and patient compliance is really important. For example, like at our hospital, we can consult respiratory therapy and they can come and do inhaler compliance with patients. And I think patients do have a hard time with inhalers often. So I'd highly recommend using your resources to make sure patients understand, especially if it's a new inhaler, they haven't used it before. Same thing would go for if they're switching from one specific brand to another. Not all products have the same exact way that they're used. They might have a different triggering mechanism or something. So just making sure that the patient understands it. I'm not going to show you these videos right now. You can certainly watch them. They go through the visualization a lot. And there's a lot of videos on YouTube out there about using inhalers. But the big things with a metered dose inhaler, and I do want you to know this, is that you inhale slowly. So metered dose inhalers, and I'll maybe highlight this here. It's slow and deep breaths for about 3 to 5 seconds, and then you want to hold your breath for 10 seconds. That's the big thing about these inhalers. And I think people think that they should maybe with all inhalers breathe fast, and that's not the case with this. You want a long, slow breath that's deep. The thing is if you breathe really fast with these, oftentimes all the medication can just stick to the back of your throat, and then it just goes down your esophagus. And that's just the nature of the propellant. And the interesting thing is that dry powder inhalers are the opposite. So a dry powder inhaler, you inhale once, very deep and fast. So both of them are deep breaths. It's just slow versus fast, the powder being fast. The idea is that the powder actually is a lot stickier. So like if you inhale the powder slowly, it's probably just going to end up in your mouth because it's not going to make it all the way back. And so you really need to inhale deep and fast, and it should go right into the lungs. Now, the difference between the dry powder and the metered dose is a propellant aerosol, so it's more of a fine vapor mist. So there's just different physics as far as how the particles travel through the mouth. So you just have to take my word for it. This is how it works, and this is the recommendation. But you can watch the videos if you want to see more of a demonstration on how these are done and see some real people using inhalers. SMIs, you can see this video here. Again, these are rare. They're branded as these Respimat products, and these are newer. Some of the old metered dose inhalers were formulated with different types of gas that had problems with, they were like greenhouse emission contributors, and so you figure like how much is an inhaler really contributing to global warming? Probably not a lot, but either way they got banned by a variety of environmental protection things. That's probably a good thing in the long run, but at the same time, so some of these products switched over to this type of thing, this Respimat, which is slightly different. Basically it's just an MDI with slower moving particles, and it lasts longer. So we can maybe do different types of medications in it. And it's considered to be less environmentally toxic. Clinical trials show that it does have maybe some more efficient drug delivery overall. Not necessarily that your outcomes are better, but that you're getting to the site of action more so. So maybe you're getting more of your medication where it needs to go, which could be beneficial in patients if they aren't responding well to other therapies. And you have better patient adherence and preference for these if you do a survey test versus a standard inhaler. So anyway, that they're an option. The thing to remember is that these are usually expensive. They're usually brand name, and most insurances may or may not I would say most insurances probably don't cover these on formulary, but you might find some out there that have it on a second or third tier. So either way, their patients are going to pay more money for these for sure than a standard metered dose inhaler. Okay, so we talked about the different types of inhalers, and I'll come back to these as we talk about the drugs, but let's start with the specific agents. We'll talk about the respiratory agents individually, and then we'll talk about how we fit those into treatment. When it comes to COPD and asthma, basically we're using all the same drugs, so that's nice. The treatment algorithms are just slightly different, and we'll point those out for you here. Okay, so short-acting beta agonists are going to be the cornerstone of any respiratory therapy or any respiratory disease. And when it comes to COPD or asthma, it doesn't matter. These are rescue inhalers. There's really one primary one on the market, and that's albuterol. And that's going to be the one that most people have. There is an alternative product called levalbuterol, which goes by the brand name of Xopenex. Get that in here. Xopenex, in case you guys want to know. And they're basically interchangeable. Xopenex or levalbuterol is an enantiomer of albuterol, and one of the side effects you get with short-acting beta agonists, as we talked about last Monday with beta receptors, you have beta 1 in the heart, beta 2 in the lungs. Well, oftentimes when you have drugs that target certain receptors specifically, you get crossover into the other ones. And these drugs generally stay in the lungs, but they do absorb systemically. So most people get some transient elevation in heart rate. However, if you puff a lot on your inhaler, you can get pretty tachycardic on it. And some people feel really jittery and uncomfortable. And if that's the case, you're going to have patients complaining, and some patients will try Xopenex as an alternative. I'm sorry I got interrupted with the phone call, so if my train of thought just disrupted, that's because it literally was disrupted recently. Anyway, let's talk about Xopenex, and we have a drug that doesn't cause quite as much of the jitteriness or tachycardia. So anyway, some patients may prefer that. Xopenex is more expensive. Insurances doesn't like to pay for it. Hospitals don't like dispensing it because it costs money, but you get patients on it, so you do what you can. And we just basically live with that. But you'll have patients occasionally that request this or prefer this for whatever reason. For the most part, these are short. Again, the name is short acting, so frequency of dosing makes it so these drugs are not good control medications. So these aren't things people should be using every day. It's always a red flag in a respiratory disease. If somebody says, yeah, I take my albuterol 6 times a day. No, you really shouldn't be taking your albuterol 6 times a day. Your albuterol should be rarely used, ideally never used. It's a rescue med. It's there for an emergency, or not maybe an emergency is a strong word, but at least an urgency where you're having trouble breathing, or you're experiencing a trigger if you're talking about asthma or COPD. Onset's quite fast, 5 to 10 minutes. You should get some effects pretty much instantly. I mean, this is going into the lungs. It's opening things up right away. It's going directly to the site of action. You're going to experience fast effects. However, you're going to get the full effect of it in about 5 to 10 minutes. So you get some effects virtually instantaneously, and then after a few minutes, that's when the lungs will fully open up with the medication in them. You're looking at usually 1 to 2 puffs every 4 to 6 hours as needed is what people write the SIGs as. Well, I'll show you some nebulizers here in a second, but albuterol comes as a nebulizer product too, and an inhaler. And the reason I'm pointing this out now is because the inhaler gives you 90 micrograms per actuation. So each time you spray it, you get 90 micrograms. That's micrograms, mcg. When you take a nebulizer, one nebulizer treatment of albuterol is 2.5 milligrams. It's a lot. So in other words, 2,500 micrograms. So my point in saying this is that you have a situation where people think, oh, I can only take 2 puffs of my albuterol. No. You can take a lot of your albuterol. And I know it's not recommended per se to prescribe it that way, or if you read a dosing monograph or a drug monograph, they won't tell you to do that. But in truth, think about it this way. Albuterol has some side effects. Yes, you can get jitteriness and tachycardia. But if you have somebody who is asthmatic and their choices are call an ambulance or take a few extra puffs of the albuterol, I would take the few extra puffs of the albuterol. Or if you're thinking about maybe they're having a really bad reaction and they're going to need advanced airway or intubation, certainly if they can hold off on that with a albuterol inhaler at home before they can get to a hospital setting, that's going to be much more beneficial to them than if they just took 2 puffs and think that's all they can do. So I think it's important to counsel patients they can do more than 2 in a severe situation. Well, this last bullet point, frequency of use associated with disease severity, that's in respect to what I was just talking about when it comes to we shouldn't have people using these regularly. The higher the increase in number of times per day used, you see an increase in disease severity with COPD and asthma. So that means that your disease is not controlled. This is a good diagnostic tool for how well somebody's asthma or COPD is controlled. If they're using their rescue inhaler a lot, that means that it's not controlled. So you can think about that. That comes up back when we come back to the guidelines. That'll be something we'll revisit here in a second, but just keep that in the back of your head for now. Long-acting beta agonists are just like their short-acting cousins, but they last longer. So we can use these medications as controller agents. So when we talk about controller agents, we're talking about our long-acting inhalers. So there's control versus rescue. The same concept here. We're stimulating the same receptors, relaxing smooth muscle in the lungs with beta agonists. There's a couple different products on the market. You can see there's several. They all are EROL. So kind of easy to remember. Remember, anything with OL as an ending is likely acting on a beta receptor of some kind, either a blockade or an agonist. And so if you remember, LABA that's an inhaler, then you can remember that OL, LABA's, short long-acting beta agonist. Hopefully that nomenclature makes a little sense to you guys. These are very similar. I'm going to talk about the combination products because they're really popular with these diseases too. So we'll get to that. What I want to tell you about here is most of these are twice daily dosing. The onset takes a little bit longer for some of these. However, formoterol has a fast onset and a long duration. So theoretically, if somebody was in a bind, they could use a Symbicort, Foradil, or Dulera inhaler, and they would get a fast-acting response from it, like they would albuterol almost, even though it's a long-acting beta agonist. So I think that can be a nice advantage to some of those inhalers because maybe they forgot their albuterol, but they have their Dulera with them, or they mixed them up because they look kind of similar in shape. You could end up with a patient who doesn't have a rescue med, but actually they can use this kind of as a rescue agent in a pinch if they needed to. Not recommended, not ideal, but certainly possible. Our formoterol is Brovana. That's a nebulized product, and it's always good to know the nebulized ones. I don't think I'm going to test. I'll just say this. I won't ask you test questions on which ones come as nebulizers. But I think you run into patients who can't use inhalers or they're on a nebulizer regimen already, and it makes sense to put them on something like this. So knowing which one come as nebulizers can be advantageous in those situations. Indacaterol is an odd one that has a COPD indication only. Otherwise, all these have indications for asthma and COPD. And there's a couple of other ones here which I'm not too concerned of. There's a product called Brio out there, which is a combo product, and Volanterol is the long-acting, and it's once daily. It's the only one that's once daily, and it's got a nice advantage from a compliance standpoint for that. It's definitely got a little bit of an edge on its counterparts here. One thing we'll come back to in asthma, you don't start people with asthma on a long-acting beta agonist. It's contraindicated to do that, and people can actually have increase in mortality with that. You can start somebody in COPD on one of these alone, but not an asthmatic patient. You start them on inhaled corticosteroid, which we'll get to on the next slide here. All right, so inhaled corticosteroids, these are just like our other corticosteroids we talked about. They block late-phase reaction to allergens, they reduce airway hyperresponsiveness, inhibit inflammatory cell migration and activation, and they're our first-line therapy for asthma. One thing to tell patients too, if you're going to prescribe this, is to rinse your mouth after you use it, because if you swallow the corticosteroid, you can have some systemic absorption of it, so that's not what we want. It's not going to the site of action, one thing, and we don't want people with systemic side effects. One of the great things about treating COPD and asthma is you don't have a lot of systemic side effects with your regimens. You're getting things directly to the lungs, and that's what you want. You can get some local immune system suppression, if you want to think about it that way, in the mouth, and people do get thrush occasionally with these. So we do recommend rinsing the mouth after, usually just with water, and a vigorous swishing and spitting is enough to do it. You don't have to do anything all that fancy. These don't have any role in acute treatment. Remember I talked about the long-actings maybe like with formoterol having a short onset. These wouldn't help you. So if you ever hear somebody, oh, I take my inhaled corticosteroid as needed, that's not going to do anything. We talked about the nasal sprays. Maybe you'll get some effect right away. You're likely not going to get any effect from these within the first couple days. It's going to take a week to really see something. Maybe a little bit shorter than that. But I wouldn't expect anybody to feel any different after one puff of a corticosteroid. That's really important for asthmatic patients to understand, because oftentimes you'll give them a rescue inhaler, their albuterol, and you'll give them just a corticosteroid. So if they know that they can't use that corticosteroid for rescue, then that helps them differentiate which one. But if they don't understand that and they're like, oh, I'll just grab my inhaler for the day, and they puff on their corticosteroid because they think it's going to help them in an emergency and it doesn't, that's a problem, of course. So that sounds like, common sense maybe to some of these patients, but it's really important that they understand this. Supplemental calcium. There is some studies out there that show that patients who take inhaled corticosteroids might be at risk for osteoporosis. Remember we talked about that as a side effect for glucocorticoid use and long-term glucocorticoid use. This isn't well documented, but supplemental calcium is pretty much benign, so there's not really any problem with giving it. You can certainly recommend it if you feel more comfortable doing that. These are the inhaled corticosteroids on the market. You can see their brand names here. We'll get to the combinations in a second here. And the dosing I'm not going to test you on. I don't care you know it, but it's there for your reference. One of the things to know is that when it comes to steroids, that's where our dose can fluctuate. So I'm going to go to the next slide because combinations are really the important thing here. Combinations come in a variety of doses. So let's look at Advair. Advair has a discus, which is this purple thing. It's one of the most common, popular ones out there. It was forever. However, I think other ones are getting more popular than Advair now. It's still quite used frequently. And it comes as a 100, a 250, and a 500. They're all plus 50 of the salmeterol. And that's the same for any combo inhaler product. You don't have a change in long-acting beta agonist dose. That's always going to be constant throughout. Where you're going to see the change is with the steroid. So that's how you can titrate the steroid dose. I think with the long-acting beta agonist, for whatever reason, they just found that people pretty much just respond to one dose and they don't need it anymore. Maybe it's a dose limiting effect, or you can only get so much into the lungs. I don't know exactly what it is, but the steroids do seem to help with the different doses as far as help with resistant treatment. So you can increase the dose of inhalers, but remember you're just increasing the steroid dose when you up the dose of the combination product. Symbicort is budesonide and formoterol. It looks like this. It's it comes as a dry powdered inhaler. Advair comes as a dry powdered inhaler and a discus. A dry powdered discus and a metered dose inhaler. Symbicort is a metered dose inhaler. I misspoke. I said it was a dry powder. It's not. It's metered dose. And Dulera is metered dose. Anything with an aerosol canister or this type of shape to it is going to be a metered dose inhaler. You can see here, it's kind of hard to see in this picture I did, but there's a dose counter on the top of Symbicort. You can see a dose counter on this Brio Ellipta product, and you can see a dose window very small here on the Advair. I'm going to bring some play inhalers. If you guys want to look at inhalers, I'll bring them in on Monday. If you guys want to check some out in real life, they're just sample. They don't have, well, actually, some of them actually do have drug in them, but they're just expired. Anyway, you can play and look at them and activate them if you want to see how they work. Brio is one of the newer, I think it is the newest product on the market out of all these. And it's the one actually our hospital switched to as our primary agent. One, because it's actually less expensive than any of the other ones. Two, it's really easy to use. And three, it's once daily. So there's a lot of advantages to Brio. I'm not trying to endorse one product over the other, but man, if I was going to take an inhaler, I would probably pick it just for the fact that it's a once-a-day dose. I don't want to have to remember to take something at bedtime every night and in the morning. I can probably do morning. Maybe I could do bedtime with an alarm or something. But I'm going to be a lot more adherent if I'm taking something once daily. And that's where Brio really shines over some of these other ones because they're all twice a day. The Brio Ellipta, again, you can play with this if you want to come into class. I'll bring one in. This light blue thing slides down this side thing. and then it exposes a mouthpiece which activates the chamber, and then you inhale the powder from that. So it's a very simple design. The nice thing is these are kind of chunky and thick, so people with problems manipulating inhalers, like with maybe diabetic neuropathy or elderly patients, they're a lot easier to use. It's not hard to use them, but they're bigger, so I think people can hold them a little bit easier. Whereas sometimes some of the stuff is small. I'm going to show you Spiriva in a second, and it's super complicated how you use Spiriva. It's an overly complicated inhaler. These are expensive. I did say that Brio is the least expensive, but generally inhalers very expensive, like a couple $100, $300-$400 per inhaler. And oftentimes you aren't seeing generic versions of these coming out. The reason is because inhalers are often tied to a specific delivery system. So, for example, you might look at this and say, well, how come Advair has fluticasone and Brio also has fluticasone? Or Symbicort has formoterol and Dulera also has formoterol? Well, the drugs themselves are all generic. Those don't have any patent left on them, with maybe the exception of Vilanterol might have something on it. But when you have a product that is tied to, or a drug product that's tied to a specific delivery product, that changes what types of patents you have. So, for example, Glaxo has a patent on this thing called the discus, which is the actual drug delivery system, not on the drug itself. So, and I don't know if that goes away ever, if the FDA has rules on when you can make generic versions, if some company could just copy a discus and make their own. I don't think they can. I could be wrong on that, but that's why Advair's been around for 20 years and we still haven't ever seen, and maybe that's a stretch, but it's been around for at least 15 years, I would say. I'd say 20 years is a safe bet too. It's been around for a while and we still haven't seen any generic for it. So I don't think we're ever going to, and I think again it's tied to this. And so that's why we're seeing other things like the general form of a metered dose inhaler that's just this mouthpiece down here and the canister. I don't think that's patent protected by anyone because a number of companies make very similar looking products. Like Symbicort and Dulera are essentially the exact same thing. Symbicort's just fancier because it's got a dose counter on the top and it looks a little nicer. Dulera is a bit more basic looking. It looks kind of like more like a standard albuterol inhaler, how you'd see that packaged. The Brio basically took the idea of what Advair is and made a better design, in my opinion. So it's like the company just redesigned the product a little bit. So again, I'm not a patent expert, but it's like, is it a utility or a design patent, or how does that all work? The point is that you don't see these like generic companies making inhalers. These are all branded companies. And I actually think, yeah, I should have noticed this earlier. But Glaxo makes the Brio products and the Advair products. So basically, they remade their own device as something better, and contains a drug that is longer acting as a once daily medication. Almost, well, I don't know if you're technically competing with yourself because you're selling basically the same thing, but they're offering a better product than their initial one. So maybe they are going to lose their patent on that discus eventually, and this is a preemptive thing to do for them, but we'll see what happens with it. Either way, combo inhalers, always expensive. The only inhalers that aren't really all that expensive are like basic albuterol inhalers are relatively inexpensive. They might be like $20-$30 for one, cash price, but everything else is pretty much expensive. Systemic corticosteroids. So while we're on the topic of corticosteroids, we can use these in exacerbations. So usually what we do is give a steroid burst. So we're using about 3 to 10 days and sometimes probably max of 2 weeks. You can usually just do the sustained dose. I'd recommend just doing the same dose for every day. If you do a full 2 weeks and want to taper somebody down, you certainly can. Prednisone is the drug we're using. Asthma, we dose it a little bit higher and a little bit more aggressively, but for slightly shorter intervals. So we might give somebody a 5-day burst for asthma, whereas COPD, we're using a lower dose and giving a 10-day. Why? I don't know if it really matters a whole lot. I think that's probably how it was studied originally, so I'm not going to comment on that further. But could you do a shorter course of COPD? Maybe, but I would stick to how it's prescribed or how it's written, how it's recommended based on probably what the studies did originally. A lot of times we do methylprednisolone IV for these people for the first dose, and then we'll send them home on an oral steroid. Remember the sustained use, you get that adrenocortical pituitary suppression, so you get problems with stress response after you're done, but that shouldn't be a problem if you're keeping it under 2 weeks. Finally, the final class of inhaler we'll talk about are anticholinergics. So anticholinergic inhalers reduce intrinsic vagal tone of the airway via muscarinic receptor inhibition, and they do decrease secretions a little bit, but ultimately they're a smooth muscle relaxant. So you get a nice, and also known as what's called a bronchodilator. So both long-acting beta agonists and anticholinergic, or beta agonists in general, I should say, long or short, doesn't matter. And anticholinergic medications are considered your bronchodilators. And when we talk about COPD, we'll talk about start them on a bronchodilator. Either one's fine. They're both probably equivalent and do fairly similar things. We'll talk about some of the rationale and where we might make some changes or some adjustments to that during the specific treatments. But for the most part, anticholinergics are your alternative bronchodilator. For a while, these were COPD-only medications. However, they've recently gotten some studies in asthma, and so we are seeing them used for uncontrolled asthma as well. So I put that question mark there on purpose. That's because they aren't COPD-only anymore. There's a long time where you'd see an anticholinergic on somebody's med list and be like, oh, it's a COPD patient, easy. Not anymore. They could be an asthma patient as well. Tiotropium is a drug called Spiriva. It was the first long-acting anticholinergic or antimuscarinic. They call them LAMAs, long-acting antimuscarinic agent. And you have this Spiriva up here. I've got it on the next slide showing how weird it is. But it's been one extremely common drug used for a lot of patients with COPD, and it was a blockbuster medication, just very, very successful. Partially because it was the only thing in its class that was long-acting. There was another drug that's been around for a while called ipratropium. I can never say that word, too many R's, or Atrovent, which is a short-acting medication. But Spiriva was the long-acting one that was the controller medication of choice for COPD. And it's a once-daily medication. You do have to do 2 inhalations each time to get all the powder out. Spiriva has reformulated itself into this Respimat product, which is what we just talked about earlier with the new form of inhaler that's kind of like the dry powdered, or not, sorry, I keep missing these up, my bad. The metered dose inhaler, the soft mist inhaler, the new kind of advanced version of that. So it did reformulate itself to a more convenient product. Is it being used a lot? I'm not exactly sure. It's a good question. I've never seen it, but I think patients might be preferring it. I think this Spiriva is kind of dying out because it's not very convenient. The short-acting ipratropium is sometimes done scheduled, but oftentimes it's considered an alternate rescue inhaler. And for a while, there's a drug called Combivent, which was a combination ipratropium albuterol that was used as a rescue inhaler. That product got taken off the market for a number of reasons. Some kind of a supply issue, and it might have been due to the propellant being, not environmentally friendly. What we ended up with is a Respimat product now available. So again, kind of this soft mist inhaler product. And that is available. It is really expensive. The Respimat products are super expensive, so I don't think we're seeing a ton of use on it, but it is available. And I don't know if it really has a great advantage over albuterol as a rescue med. What we do see this used more so is in the nebulizer world. If you have somebody with really uncontrolled respiratory issues, sometimes they'll just have them on like 4 times a day nebs, and they'll be doing combination nebs called duo nebs, which includes ipratropium and albuterol, and they'll take those 4 times a day. So that's where we see that drug used more so. There are 2 new anticholinergics. So I said Spiriva had been around forever, but now there's 2 new ones, aclidinium and umeclidinium, or Tudorza and Incruse. I've seen both of them used, and we've seen a big uptick because we're using this one now. Incruse is, I don't have a picture of it, but it's the same company. It's GSK's version of an anticholinergic. So it's the same Brio style. It's just a green one. And it's a dry powdered inhaler that's once daily dose. So it's a convenient medication that they're packaging like that. This is how Spiriva works. So I'll bring one of these in so you can play with it if you want. But you pop open this little egg-shaped thing, and then you pop open the mouthpiece again, and then you take a capsule that comes separately, you put it inside here, you crush it with this little trigger thing, or you pierce it. It's like this little spike thing goes through it, and then you inhale it twice. Tons of steps to manipulate. You have to remove a capsule from a blister pack, place the capsule into the thing, open it, open 2 different things, close them. It's just a lot of work compared to something like any of these inhalers, really, the new ones like the Tudorza or the Incrus, or even the new Respimats are going to be so much easier to use. Spiriva is just, I don't know who invented it, but it's not. It's a delivery method that isn't all that convenient for patients, especially somebody who's elderly, has problems with dexterity, might just have some significant issues with making this work. So that's going to affect adherence for sure. Oh, and here's a picture of the Incrus or the umeclidinium from Glaxo, and you can see it open. So again, this is the same thing as Brio. It's just a different medication they're putting in it. The doses or the system's exactly the same. And again, it's quite easy to use when compared to this one if you want to look at them side by side. I've had some videos of kids using nebulizers if you're curious as to how they work. Patients may prefer nebulizers. It's going to be a tough sell for the average adult with any type of activity, because nebulizers, you have to sit down and use the machine for about 15 minutes probably to get 10 to 15 minutes. Nebulizer machines are kind of expensive right away. Most insurances pay for them. It's not like you're buying them every time. You buy one neb machine and then you're good for a while. So people use nebs for a variety of reasons. Like kids might use nebs. It's just easier than having them use an inhaler if you have a child who's asthmatic. Adults who are either maybe they're just going to respond better to the nebulizer, or they're in a situation where they're not very mobile and they're getting home care daily, so nebulizers. Nebs, if you discount the machine price, or even if you include the machine price, nebs are really, really cheap. So like a neb costs like maybe 50 cents for one nebulizer treatment. You're talking about hundreds of dollars for inhalers, because you're paying for that delivery system that's patented and fancy. Whereas a neb is just a plastic vial of medication that's generic. So nebs are super cheap. So when we're in the hospital, if we're ordering like as needed stuff, a lot of times we just stick to nebs, because any nurse can give a neb. They can hook them up to the machine in the room, the oxygen flow in the room, and hook a neb in. Super easy, very cheap, versus ordering an inhaler that they're going to get, and it's going to sit, and they might not use it, and then it's a waste, and you spent all that money for nothing. So just think about that. And again, you can watch these videos if you want to see nebs in action more so. Okay, we talked about this briefly last week, but lipoxygenase is a enzyme that converts arachidonic acid into leukotrienes. So leukotrienes have an inflammatory response in the lungs, and so these drugs generally are just designed to block this process. So either on the enzyme or on the receptor. You get a lot of variety in how patients respond to these. They work kind of slowly, so not for acute situations. These are things people take daily to prevent things from occurring. They aren't going to take these in an acute exacerbation. Sometimes you can take them, maybe we'll talk about an exception to that during exercise-induced asthma, but for the most part, these are not acute medications. Some carbon targets. So we have direct receptor antagonists, montelukast and zafirlukast. And montelukast is singular. It's been around for a long time. It's the most popular one for sure. It's generic now, so it's relatively affordable. It comes as a pediatric chewable tablet. Zafirlukast is another option. There's one that inhibits a specific subtype of lipoxygenase, and that's called Xyluton or Zyflo. It's twice daily, and it's quite expensive. I don't see that used a ton. Singular is by far the common one. Xanthine derivatives act as direct bronchodilators. We don't really know the exact mechanism, and they aren't really utilized a lot in current practice. They're actually, caffeine is a methylxanthine, and why exactly they act in the lungs, we aren't totally sure. There's more evidence in COPD exacerbation versus asthma, but this is something that you could use in a situation where somebody's having a really bad asthma exacerbation. You've tried everything, and nothing's working. Theophylline might be considered to be given. We'll talk about it more during pediatrics, but we use caffeine for apnea in premature infants, and that does work quite well for that. It's a first-line therapy. So there's a lot of options, well, a few options here, but not a lot of utility overall. overall for the general patient. This is more of a niche thing that we're talking about here. So don't spend too much time on it, but you should have a general idea about xanthine derivatives. All right, Xolair is an IgG monoclonal antibody. It inhibits IgE binding sites on mast cells and basophils, so you get limited activation and release of allergic response mediators. And this is for people who have a really strong allergic component to their asthma. It's subcutaneous every 4 weeks, weight-based dosing. It's not studied in kids less than 12, so we don't really know about them. And it's got about a risk of delayed onset anaphylaxis, which could be anywhere from within 1 hour of taking the medication to up to a year taking it. Most patients occur with less than 60 minutes with the first or second dose, but there's still that risk that you can have a sudden anaphylactic reaction with the drug after you've been taking it for your 6th dose, and 30 minutes into it you start to have an anaphylactic reaction. It is possible. It's expensive, but it is an option for patients with really poorly controlled allergic response-related asthma. All right, so we'll start with asthma for treatment guidelines. The asthma guidelines, if you want to look them up, are located at that website below. They're pretty straightforward, and again, both asthma and COPD have very similar treatment strategies, just subtle differences. And I think it's pretty straightforward as far as treatment goes, but we'll talk about the disease and the treatments for both asthma and COPD in the next several slides. So asthma is a chronic inflammatory disorder where you get waxing and waning of airflow obstruction. It's considered bronchial hyperresponsiveness. It affects about 7% of the U.S. population. It's a common childhood illness and responsible for a lot of pediatric and adult emergency department visits. Death from asthma is fortunately pretty rare, and deaths from asthmatic attacks are usually 80 to 90% preventable. And our major primary prevention methods are rescue inhalers. The other thing would be is quick access to EMS personnel. If you can get an ambulance to you, they can make sure your airway stays patent, give you breathing treatments and that type of stuff. This just shows asthma and the smooth muscles surrounding the lungs, or surrounding the different parts of the lungs that tighten and cause constriction during a inflammatory response during an asthma attack. Asthma is usually triggered by something. A lot of people with asthma also have allergies. There could be some sort of household type thing, tobacco, smoke, wood burning stoves, chemicals in the house, like if you have cleaning, renovations, painting, that could be a trigger for patients. Pets, certain types of animals. Workplace specific, if you work in like an industrial chemical factory, might be a higher risk of getting an asthma trigger exposure than somebody who works like in a sterile environment. Who knows? I'm trying to think of an example of the opposite of that. Outdoor allergens would apply, so trees in the spring, grasses in the late spring, weeds in summer and autumn. Other medical conditions, but yet risk allergic rhinitis, which comes with allergies, of course, that causes a postnasal drip. GERD, aspiration of food, can get into the lungs and cause inflammation. Medications, beta blockers and NSAIDs can cause some reactions too. So the reason why beta blockers are thought to have to do with asthma is because if you take a beta blocker for a heart condition, you end up with suppression of beta receptors. Now, most beta blockers we use are selective for specific beta-1 receptors on the heart. Some are non-selective, and some beta blockers, even if they're considered to be selective, might have some beta-2 activity as well. So if you have somebody on a beta-2 agonist as their medication, whether it's a short-acting or long-acting for asthma, and they're also on a beta blocker, well, if you are blocking the beta-2 receptors in the lungs and you try and give a beta agonist, you're going to end up with a conflict of interest there, right? So that's one of the problems with beta blockers. And we talked about NSAIDs being anti-inflammatory. This is a little bit more theoretical, not necessarily proven, and certainly not a contraindication to asthmatic patients. But the idea is that if you took an NSAID and it's blocking production of the COX-related inflammatory mediators like prostaglandins, prostacyclins, you can end up shunting processes through the leukotriene production pathway more so. So you just upregulate that side because you have inflammatory mediators that the body has production of, and your body wants to use it. So if you shut down one side of that pathway, it's going to take the path of least resistance, which is to go through those other enzymes to get produced into other leukotrienes, which can cause more respiratory issues. So that's just a theoretical thing. It's not, again, not a contraindication, but it's something that could possibly be clinically relevant in certain situations. Our goal is to reduce impairment of intensity and frequency of symptoms. So freedom from cough, chest tightness, wheezing, shortness of breath, sleep disturbances. We want to have people having minimal use of rescue medications, optimizing lung function, maintaining normal daily activities, reducing risk in the workplace, or reducing risk overall, preventing hospital ER visits, reduction in lung growth and development for kids. We want to prevent that. We want to prevent pharmacotherapy-related adverse effects as well. Monitoring, I'm not going to test you on monitoring, but I would like you to be able to know what somebody who maybe has intermittent or relatively non-severe asthma versus somebody who's in a more advanced state of their disease. So for example, with intermittent asthma, you're looking at somebody having symptoms very infrequently, 2 days a week or less, nighttime awakenings, again, infrequently, short-acting beta agonist use is infrequent, and then you can see lung function tests. I'm not going to go through lung function tests specifically. Hopefully you'll do that a little bit during Clin Med. But suffice to say, what we're looking at, these are pulmonary function tests. So we want to see these numbers elevated and high, like a normal patient without asthma would have. Persistent asthma, so different from intermittent asthma, would just mean you're increasing all your symptoms. If I gave you somebody who's obvious, that might be a test key that you're going to do a more aggressive treatment. So that's where I'd want you to know some of the differences here. And really, I'll make it pretty clear. Like, I'm going to tell you that somebody's using their rescue inhaler several times a day. So if I tell you that, or daily even, if I tell you one of those two things, that should be a good clue that I'm trying to give you somebody who's got uncontrolled asthma, versus if I say, well, they're doing it 1 to 3 days a week. Well, that won't help you on a test, right? So I'll try and make it really clear what I'm getting at, but I would like you to be able to recognize like a severe case versus a intermittent case. I'm not going to go through PEDS because I'm not going to test you on PEDS for this exam, but it's here for your reference, and because it is a pediatric illness, I think it might be worth reviewing, especially if you have an interest in that area. And pediatric management is very similar. It's pretty much the same as adult management. And adolescent, or I guess this isn't really adolescent, but older kids would be pretty much the same as well. You start adding some oral therapy onto older kids. And then this is the most important thing we have here as far as treatment goes. So step 1, for somebody with just intermittent asthma, here in this column, you have a short-acting beta agonist as needed, and that's really all you need. You don't start people on controller medications until they get to the persistent category. With persistent, you're always going to look at starting with inhaled corticosteroids. Remember, we talked about that with the drug specifically. First line for asthma. And then there's some alternatives here. I would just sort of ignore these. Basically, these aren't well proven, and they aren't associated with as good of outcomes as these. Now, if you had somebody who was like, I'm not taking an inhaler, I refuse to do it, I'm in school and I don't want to have to use my inhaler because kids make fun of people who use their inhaler, something weird like that. You could try strategies, of course, to say, well, why don't you use your inhaler at home or something like that. But anyway, in this case, maybe you have somebody who's adamantly opposed to that. Well, you could try maybe like a leukotriene receptor antagonist, which would be like montelukast singular. I wouldn't use cromolyn or theophylline. I would just probably stay away from those altogether. But the inhaler should be sufficient for most people. Also, we have once daily inhalers. Remember, the fluticasone product in the Brio component is a once daily fluticasone. So for people who are saying that they don't want to use it at school, like kids, well, there are options for them. So don't let them get away with it. Step 3 involves just basically adding on or increasing your dose, and it's really, you could do either one. Step 4 means you're going to be at a medium dose corticosteroid, plus you're going to have that long-acting beta agonist on board. And remember, with asthma, we don't use long-acting beta agonists by themselves. They have to be used with the corticosteroid. That's an important distinction between asthma treatment and COPD treatment. Step 5, you're looking at max dose inhaled corticosteroid plus long-acting beta agonist. And then if somebody has a really bad allergic response, this is somebody who might want to consider that omalizumab, which is the IgG product to help with the allergic response, because ultimately you can only manage symptoms so much. If somebody has really bad allergies, they might need a little bit bigger gun to treat that. And finally, step 6 is like your asthma is kind of way out of control. You're on oral corticosteroids. You're considering this drug again for allergic response, and it's something that we want to make sure people have access to a healthcare provider. This is a bad situation, and you want to be able to be in this step 6 for as little time as possible. So you want to step down as soon as you can. The step down and step up here is important, I think, to just think about from a patient perspective. So if you have somebody whose asthma has been really well controlled, maybe they got to persistent symptoms, you started them on an inhaled corticosteroid, they did really well for a couple of years, and they're like, could I try not using my inhaler anymore? I feel like my allergies have gotten a lot better, or whatever it might be. And you say, sure. So they stop. You give them, never take away their short-acting beta agonist. They should always have that available to them. But giving them their, taking away their long-acting inhaler and see how they do. They might do fine. They might feel they have they might start feeling like they're using their short-acting a lot more. And so just make sure they're keeping in touch with their symptoms and understanding what to look for and what are the triggers there that would make them maybe a candidate to stay on that inhaler longer. So this is 2015, and oops, sorry, I got a phone call here. Sorry about that interruption. This is the GINA guidelines 2015. It's the same. It hasn't changed at all. So I didn't update this per se. But you could read. I don't know if they've came out with new guidelines even, but there hasn't been any new revelations in the asthma treatment world. The biggest change within the last 5 years was this on step 5. And step 4, you can see add tiotropium. So this would be different from these algorithms we looked at before. They don't mention the long-acting muscarinic agents on this slide, so there's no anticholinergic drugs. So remember I said that historically anticholinergics were never used for asthma, they were only COPD. Now actually the current guidelines are recommending that they be added for uncontrolled step 4, step 5 asthma, depending on your symptoms. So that's a newer thing. It makes sense pharmacologically. There's really no reason why we ever couldn't use these in asthmatic patients, and I suspect for uncontrolled asthma it was getting used for quite a while and just maybe not studied, and finally they came out with some evidence to say, yeah, this actually works well for asthmatic patients, and it does have some benefits that we're finding clinically. So anyway, the point is that you can do what we call triple therapy in an asthmatic patient, which was previously only a COPD thing. In asthma, you can use the triple therapy, which is inhaled corticosteroid, inhaled long-acting beta agonist, and inhaled antimuscarinic drug. So that combination, 3 inhalers, and you've got that triple therapy covered. So that would be the big difference again between the new guidelines. So when I test you, if I ask you a question about triple therapy, it does apply to asthma. So I want you to know this. I leave this in here because I like this diagram. I think it's easy to read and use, but the GINA guidelines have the updated treatment pathway there. For exercise-induced asthma, which is sort of like an acute episode of bronchoconstriction, it doesn't necessarily mean you have chronic, long-standing asthma. It could happen. Some people can give themselves exercise-induced asthmatic-like symptoms, but for somebody who has asthma, they might, or really maybe they have intermittent, well-controlled asthma. This could be something that comes up every once in a while, especially if they exercise a lot. Usually what people get is 6 to 8 minutes after exercise, usually resolved after an hour, shortness of breath, chest tightness, and cough. Beta agonists are the easiest way to do this. So if somebody is prone to this, prescribe them an albuterol inhaler and tell them to use it 10 minutes before they exercise. That gives you a couple of hours of beta or bronchodilation, and so you should be able to get through whatever workout regimen you're wanting. If you want to repeat, certainly fine. I would tell patients to be wary of tachycardia, not to use it too much, especially since they're exercising, and you would have that tachycardic response as well due to the exercise. So you don't want to compound that. But for the most part, it's going to be well tolerated. Long-acting agents is something that you could try. So like let's say maybe you have a patient who they exercise daily, they're marathon runner. They're always running, always biking, they're always doing something aerobic, and they struggle with this. So you just put them on a long-acting product. You could, some people tend to develop tolerance to that, though, and it just might not work quite as well. For prophylaxis, it tends to work better just exercise. Now, it all depends on your patient, too. What if your patient has asthma symptoms when they aren't exercising? They might be on the inhaled corticosteroid as is, so maybe that's a better option in the long run. If you have somebody who's struggling with exercise-induced asthma, they're using a short-acting beta agonist. And remember, we don't want to use long-acting beta agonists alone in asthmatic patients. So you have a little bit of a problem here. Now, I did put formoterol here. So this is where it gets a little tricky because for a standard asthmatic patient, we don't want to use beta agonists alone. With a drug like formoterol, you could technically use it in somebody who just has exercise-induced asthma and doesn't technically qualify for the actual asthma disease like we're talking about with the previous several slides. So hopefully that makes sense. They're kind of separate, but they can certainly be concurrent as well. So you just have to use your clinical judgment and understand what your patient is. If your patient's a long-standing asthmatic, but maybe they're pretty well controlled with intermittent symptoms, you still wouldn't want to use a long-acting beta agonist alone. If you wanted a long-acting agent, you'd probably want your steroids to be on board with a long-acting inhaled corticosteroid. And again, only if poor control of asthma. And that's sort of a general statement there. So of course you could have somebody who's got well-controlled asthma and all of a sudden decides to start training for a marathon, and then they end up with all these exacerbations. Well, maybe they need to go back on their steroid in that case. So it's poor control, but it could be situationally due to whatever's going on with the patient's life as well. So it's not necessarily under their control. If they want to exercise, they probably should. It's really good for them. So if we can add a little medication to help them out, it's probably good to do. But again, remember, steroids aren't a quick fix, so make sure they have that short-acting beta agonist available. Some people have used Singular as well. It's a little trickier on the timing. 2 hours before your exercise is about when you should feel the protection, so you do have to take it regularly. Singular's got a decent half-life, so you could take it every day and probably be okay. But you're going to get peak effects 2 hours after your single dose. So ideally, you take it 2 hours before you're going to exercise. And this would really be for people who have allergic response-related asthma. So maybe you have somebody who doesn't have asthma really, but they exercise a lot, and during the fall every year they get really bad exercise-induced asthma because of fall allergies. Well, this could be a good person to try this on and see if it works. But you could certainly do the short-acting beta agonist as well. No problem there. For exacerbations, you're looking at breathlessness, inability to speak, use of accessory muscles, and drowsiness, usually because patients start to get hypoxic. Treatment is to use your short-acting agents as quickly as possible, so albuterol or ipratropium or both. 4 to 8 puffs. Remember, we talked about usually you tell people use 1 to 2 puffs as needed. Well, you can go up much higher than that. So 4 to 8 puffs. You could double that even, say 8 to 10 to 20 puffs. I wouldn't, again, recommend telling everyone to do that, but if you're facing the ambulance or an emergency department visit, or your person's about to pass out and you could maybe get them to respond with a little bit more albuterol, certainly give more. Remember, nebs have a ton more drug than that, so you aren't even approaching half. Even with 10 puffs, you aren't approaching half of what a nebulizer would give you as far as dose goes. So ultimately, EMS is going to arrive. They're going to give you a neb. You're going to feel better. They're going to give you high flow oxygen. They're going to give you IVs. You're going to get to the emergency department. They're going to give you IV steroids usually. We like to use magnesium sulfate a lot, which is a drug we haven't talked about. Magnesium generally has a smooth muscle relaxation effect. They use it in OB a lot for certain indications. It relaxes the uterus. It can have antihypertensive effects, but it actually has been shown to be pretty good if you give a high dose of magnesium IV over 20 minutes. It can help with life-threatening exacerbations that aren't responding to respiratory treatments. If allergic response is suspected, if anaphylaxis is suspected, we're going to go back to our anaphylaxis discussion from ENT. Epinephrine, diphenhydramine, and spelled diphenhydramine, right? Bad pharmacist. Diphenhydramine and famotidine, and that's going to give you your histamine response blockade and your catecholamine to help with the peripheral vasoconstriction. And it'll also target beta-2 receptors systemically as well, so you're going to get lungs to open up more so even than with the albuterol. So you get a number of things going here. And then we talked about methylxanthines briefly and how they're kind of controversial. This would be sort of a last line option to try. The goal is to do all this stuff and to prevent somebody from being intubated. I've seen tons of asthma exacerbations, and I don't think I've ever seen somebody get intubated. And I've had a lot of people come in and be like, oh, this happens to me all the time. They always have to put a tube down my throat. If you manage somebody correctly, you don't have to do that. You get a respiratory therapist involved. You do these things, you're going to be okay in most cases. A lot of it, honestly, revolves around having a really good respiratory therapist. They can make a big difference in these types of cases. All right, moving on to COPD. COPD has a set of guidelines called the GOLD guidelines, and there's the link there if you want to check them out on your own. They don't change. They haven't changed much in the last few years. There hasn't been a lot of new therapies come up. But COPD is sort of the same type of disease as asthma and the same sort of treatment strategy, but it's a totally different patient population. Think of asthmatic patients as young. They usually don't have a lot of comorbidities, although they certainly can. But it's a disease of somebody who could be otherwise totally healthy, but they just have asthma. With COPD, this is usually highly, highly associated with cigarette smoking. That's one of the biggest links directly to it, and probably the majority of COPD cases is related to cigarette smoking. There could be other causes like environmental exposure and genetics, but for the most part, you have cigarettes being your primary source here. To highlight this point a little further, you can see this curve here, which is showing a couple different things. So curve A is normal lung changes over time. So lung function peaks in the 20s and 30s and kind of slowly declines after that with age. And then B shows somebody who has reduced lung growth and maybe has some sort of a developmental abnormality going on with their lungs and how that would compare. Curve C shows a premature decline in lung function, and curve D depicts accelerated decline in lung function. So this is basically going to be your smoking patients here. So somebody who starts smoking is going to drop down from somebody who's normal to somebody who has premature lung dysfunction, some sort of a premature growth dysfunction of their lungs. The point is that when you look at this, is how the impact is of lung dysfunction. Interestingly enough, and they don't really have a chart to show this, but like if you stop smoking, let's say this person stopped when they're 50, what you get is sort of a dotted line that sort of follows this A curve. You don't necessarily get back to your lungs, but lungs are pretty resilient, and assuming you didn't get cancer or anything, they can clean themselves out and rebuild themselves a little bit. So it does take quite a bit of smoking. And it's interesting if you look at the stats that some people relatively large percentage of people who smoke never get COPD, which kind of blows my mind that you could smoke every day for your life and not get some kind of a lung disorder. But statistically, just not everybody gets it, but a lot of people do. And this will show you, anytime if you start smoking, when you're 35 or 40, wherever this is, you're going to get accelerated decline. It's going to sort of match up with what this looks like here. This chart just is, the point of this is people are like, well, COPD versus asthma, what is it? Well, it's all sort of related. I mean, we talk about obstructive versus restrictive, and to be honest, I don't really care about that. I don't think it's a big deal. The drugs work on the exact same mechanisms of action, and they treat the same diseases, which means that pathophysiologically, you have very similar processes going on, regardless of how you want to break up the disease. Yes, they are different, but they're certainly treated the same way. So COPD, there's kind of three standard symptoms you look at: dyspnea, chronic cough, and sputum production. Those are your metrics for how well you're doing. How short of breath are you getting? How much are you coughing? And how much sputum are you coughing up? Wheezing and chest tightness, one more common with asthma, less common with COPD. Presentation, sedentary lifestyle is usually common. So a lot of people might just, as their COPD is a slow progressing illness, so it's like all of a sudden, you're not like asthma where all of a sudden you might have an attack and like why, with an allergic response. With this, it's slowly, maybe a person gets a lot less active. Maybe all of a sudden they realize, you know what, I just can't tolerate exercise very much anymore, and even walking makes me really short of breath. Is there something wrong with me? And they just sort of adjust their lifestyle to this this limitation, and maybe it's because they're smoking a lot, or maybe something else is going on. But the point is that you slowly creeps up on a lot of these patients, and by the time we're trying to help them, it can be too late to really do a lot. We can maybe help with some of the symptomatic relief, but it's very difficult to improve lung function once COPD has been really advanced in a patient. Respiratory symptoms, usually only on exertion patients are getting, but eventually once the disease gets worse and worse, you'll notice it at rest too. So people will sort of have symptoms all the time. They might need chronic oxygen. They might need round-the-clock nebulizers at that point. And the diagnosis can be confusing for COPD patients. They could look like they have an infection. So it could look like they have some sort of pulmonary infection like a pneumonia. Also look like they have congestive heart failure. Congestive heart failure we'll talk about next block, but it's a big symptom can be pulmonary edema, where the fluid backs up in the lungs, which can present very, very similar to this. So it looks almost identical to COPD exacerbation, but you can see it on imaging. Goal of therapy here, we want to preserve function. Non-pharmacologic options are as important as pharmacologic options. We want to support smoking cessation, reduce other risk factors if they have environmental or something like that. Vaccinate the patient. These patients are at really high risk for pneumococcal pneumonia, so those vaccine and influenza too. Those vaccines are really important. Oxygen therapy can be important. Pulmonary rehabilitation is something I don't know a lot about, but I know it involves working with respiratory therapists and doing breathing exercise and things like that to improve lung function. That can certainly help too. I don't know if you guys get a class on that, but hopefully you get a chance to talk about that in another class. This is an older chart from the GOLD guidelines, but it's still pretty relevant today. I've got some newer charts coming up. I like this one again because it sort of combines everything at once. It's nice and colorful. You've got 3 easy ways to think about COPD, which aren't the technical correct terms. We'll get to those in a second, but mild, moderate, severe, and very severe. And that has to do with how your pulmonary functions are. So this is what the different gradients are looking at. And then looking at active reduction of risk factors, and then adding the short-acting bronchodilator. So those are going to be classified for any patient with COPD. Just like any patient with asthma is going to have a SABA on board, any patient with COPD will also have that. Now, the difference is the first step, and that's where we're going to start somebody on a long-acting bronchodilator and add the rehabilitative services as well with respiratory therapy would be good too. But this is where these are flip-flops. So with asthma, remember, we're starting with leukocorticoids and adding the long-acting beta. In this case, we're starting with bronchodilator and adding glucocorticoid. So in this case, you can start with either a long-acting beta agonist or a long-acting antimuscarinic agent. Now, this is more the appropriate way to look at it as opposed to just saying mild, moderate, severe disease. It's the A, B, C, D categorization. So this breaks down your exacerbation histories with some different diagnostic tools like FEV1 and some of these things, which I honestly don't really understand all that well. But this is how you would break it down further if you're actually diagnosing somebody. So you actually put people in these A, B, C, or D categories. And again, I don't care that you know the diagnostic stuff, but when it comes to drugs, that's where the current guidelines are recommending treatments. So they're looking at those diagnostic criteria, and they're putting them into patient groups, and then we choose them there. So it's really the same as that slide I showed you 2 slides ago, but it's just put a little differently. So with A, again, you're using some sort of PRN rescue meds, so either a beta agonist or your anticholinergics, so ipratropium or albuterol. Alternative choice, you could start somebody on a long-acting agent right off the bat. There's no problem with doing that, but technically you don't have to. But if you get to category B, you should be on a long-acting anticholinergic or a long-acting beta. And then choice C, you're keeping that beta agonist or anticholinergic. And remember, these drugs don't change dose. So when we're dose adjusting people, we're only dose adjusting inhaled corticosteroids. So you don't go up on your dose at all with this because there is nowhere to go. You start on a dose, you stay there, that's it. With the inhaled corticosteroid, you can start them on an ICS, and then you could titrate the dose maybe within C here. And ultimately, at the end of the day, you're going to end up at the triple therapy, just like you would with the GINA guidelines, with your corticosteroid, your beta agonist, and your anticholinergic. Just one clarification point. I did talk about asthma. Remember, we don't start people on long-acting beta agonists by themselves. It's contraindicated. It's not contraindicated to start somebody on an inhaled corticosteroid right away. It's not like there's a mortality increase. However, it has been shown to have poor outcomes overall. So they have studied this and they found out that, yeah, actually bronchodilators are the preferred drug and people do better on them overall. The inhaled corticosteroid, just due to the lack of the different inflammatory processes that are going on with COPD, it's just not as effective of a medication. It certainly does have some benefit and it is part of the algorithm, as you can see here, but you end up with a preference toward the bronchodilators. All right, so just to review some of this, treatment. First step, we start your bronchodilators. This is your short-acting beta, your ipratropium, combination therapy, like with that ComboVent inhaler I mentioned, which is both of these combined, albuterol plus ipratropium is an option. Moderate, we're looking at you always want to keep that short-acting on board, of course, but we're going to add our long-acting beta or a long-acting anticholinergic. Severe, you're adding your inhaled glucocorticoids, plus your whatever you had up here, whichever one you picked, and then very severe, you're doing triple therapy. Okay, so if you're starting somebody, is there a better long-acting bronchodilator? So do you use a beta agonist or an inhaled corticosteroid? They both appear to be effective, and evidence is pretty conflicting. So one of the biggest trials to date showed that tiotropium, an anticholinergic, was more effective than salmeterol, and that was in 2011. People who used the anticholinergic increased their time to first exacerbation, reduced risk of developing exacerbation by 17%. So it was statistically significant. There was some clinical evidence to support that. However, there was a trial in the Journal of Respiratory Care in 2010 that showed that indacaterol, which is an older long-acting beta agonist, was as effective as tiotropium. So again, biggest trial showed benefit, but there are some smaller trials that show that there really isn't any difference. I think for the most part, people tend to start COPD patients on an anticholinergic. You don't have to, but that's probably where the majority of the evidence points you. Not to say you'd be wrong to start them on a beta agonist, but that's just generally what's done in the real world, is they're started on the antimuscarinic. And I started talking about this briefly, and I should have waited till this slide, but glucocorticoid use secondary to bronchodilators decreased exacerbations and slow progression of respiratory symptoms. So that's good. However, it doesn't really have any impact on overall mortality, so it's sort of neutral on mortality and lung function tests. It seems to improve. So what we're talking about here is you have a improvement in symptoms, but not in mortality. So you aren't going to hurt somebody by doing this, but again, monotherapy is just not effective overall when it comes to mortality benefits. So it sort of, again, has that neutral effect where if you prescribe it to somebody as monotherapy, it's not like asthma where you're going to possibly hurt somebody, although you aren't giving them the correct treatment. So you could make an argument that you might be doing it that way. But the point is not to do it. So I should stop talking about prescribing it as monotherapy, because just don't do it. You won't ever do it in the real world. It's just, again, flip-flop how asthma is done. We use these first line. We use the bronchodilators first line in COPD. Glucocorticoid combination with long-acting beta agonists is the gold stage 3 or 4, patients group C and D, and reduction in moderate to severe exacerbations was shown in a trial in 2018 with that combination. So we did show that this symptom is carried over, or these symptomatic reliefs benefits are carried over with combination as well. So they do work. They're beneficial for COPD patients, but just mortality benefits aren't really there. Treatment, triple therapy. So this is all three. There was one trial called the Uplift trial in 2008 that looked at 2/3 of the patients on just the, interestingly enough, this is kind of a weird trial because this probably won't ever be done in real life, but they did a long-acting beta agonist plus a long-acting antimuscarinic, or long-acting beta agonist plus muscarinic plus corticosteroid. In real life, you'd probably have one of these plus a corticosteroid, or all three. You wouldn't really have this combination, although you certainly can. It's not really wrong, but guidelines would say to do one of these two, add your corticosteroid, and then add the other one, as opposed to doing the opposite. But That's just the way they did the trial. Anyway, they showed all three of these together significantly improved airflow, reduced exacerbation, improved quality of life. The question is it just because there's a corticosteroid? Now, if we had a LABA or a LAMA plus corticosteroid plus triple therapy or versus triple therapy, would you have seen the same results? We don't know. Either way, you didn't see a reduction, did not reduce decline in FEV1. And other trials have shown pretty similar results to this, where you can improve quality of life, you can improve exacerbations, which is all good, but you don't really improve lung function over time or decline in lung function. You aren't regenerating lungs, you aren't helping the lungs fix the problem that's going on. That's the big issue with COPD, is that a lot of this, when it comes down to it, we spend a ton of money on treating COPD, and a lot of it's just symptomatic relief. We don't really have anything that's improving lung function. That's where probably the respiratory therapy aspect comes into handy, where that might be the better option. Not to say we shouldn't do this, because we probably should, but in addition to the inhalers, they probably should be doing some sort of rehabilitative medicine there, a pulmonary rehab, to help maybe try and restore some of that function, if it's even possible. For people on 3 inhalers who aren't doing all that well, theophylline is a medication you can try. It's a low dose, give it orally. It has a lot of metabolic interactions, so drug-drug interactions, issues with liver failure and metabolizing it, and it has a pretty narrow therapeutic index, so toxicity can be an issue with it. There's a drug, a PDE4 inhibitor called roflumilast, which I haven't talked about yet. It's PDE4 inhibitors or PDE stands for phosphodiesterase. I don't know if we've talked about this. Maybe we have, I can't remember. But anyway, phosphodiesterases are a group of enzymes, and they control a lot of different functions in the body. All I care you know about this is PDE4, and this specific group of enzymes works on a variety of immune cells. So by inhibiting it, you prevent the activity of the immune cells. Dalaresp is a once daily oral medication. It's expensive, but has actually been shown to improve FEV1, prevents exacerbations. However, the quality of life effects aren't that great, so people don't really notice that they're breathing better, don't feel like they're improved like they would with inhalers. However, you're getting the improved values in FEV1, so it might actually restore some lung function. It's kind of an interesting catch-22 there, that your drugs that the patients are going to feel the improvement from don't really work long, or don't really have a great long-term benefit, but the ones that do maybe improve the FEV1 don't have the quality of life effects. Ultimately, end-stage COPD, lung reduction surgery, lung transplant would be kind of the end of the line options for these patients. Exacerbation would be an acute symptom beyond baseline. 70 to 80% are usually respiratory infections, which is why those vaccines can have such an impact in this patient population. Viral infections are most common, so some of the stuff we can't, rhinoviruses, parainfluenza, RSV, those types of things we just can't do anything about. We can't vaccinate against those. And a lot of times, if you do a sputum culture to see what the source is, you're probably going to find maybe a mix of bacteria and DNA, so it's not really all that beneficial. Usually, as far as bacterial infections, we're looking at Haemophilus, Moraxella, Streptococcus pneumo, so kind of your upper respiratory pathogens, what you think about with that. Pseudomonas, Enterobacteriaceae, not common, but maybe in really severe recurrent patients who have been hospitalized a lot or are immunocompromised, you might see that. Atypical is really rare, less than about 5% chance to see an atypical infection. And so we'll get to the treatment here in a second, why it's a little wonky in my opinion, but it's just the way it is. Co-infection, usually have bacterial and viral going on, and that's not uncommon. You can diagnose something with a sputum culture, but again, you might get a lot of noise with that. You might not necessarily find a pathogen. So supplemental oxygen, PRN inhalers, NEBs are often used during the exacerbation period until it's done. Systemic glucocorticoids, we talked about burst steroids, that would be oral steroid therapy would be fine in this case. Xanthines are not recommended. Antibiotics, 3 to 7 days of treatment. This is where, again, the treatment gets a little wonky. Doxycycline is probably the drug of choice. It covers strep pneumo pretty well, covers all the other things. It does have some atypical coverage, too, in case you have that 5%. Azithromycin historically has been really commonly used for COPD, but because strep pneumo is a player, I probably wouldn't use it. I would stick to doxy or just do a 3rd-gen cephalosporin.
It'll cover strep pneumo quite well. Bactrim will cover strep pneumo well. Fluoroquinolones, I'd probably stay away from unless you have a full-blown pneumonia. And sometimes it might be hard to tell, or maybe you have imaging to support that, but you could have a really bad COPD exacerbation that kind of starts to look like a pneumonia, and it could be difficult to blur that line. So maybe you do want to use like a levofloxacin or moxifloxacin. And then if somebody has a history of Pseudomonas, you may want to consider IV therapy because you aren't really going to target that all that well. You could get some of it with a respiratory fluoroquinolone like levofloxacin, but ideally there'd be a better option than that out there for them. There have been some studies in the past that looked at chronic antibiotics. So daily azithromycin and moxifloxacin have been trialed, which bothers me for a number of reasons that they even tried this because it's probably bred a lot of resistance in these patients. But they basically found that people at high risk for recurrent exacerbations could try this, and it was not successful. They didn't show any improvement in this with these patients taking these antibiotics. They only showed increase in resistance to certain pathogens. So it wasn't a good trial that ended up turning out well for anyone. Unfortunately for those patients that signed up for it, but they thought they were pretty promised, but it just didn't work out. So we don't do chronic antibiotic prophylaxis for COPD exacerbation. And that's it for COPD. You can think about questions you might have, and we'll do, again, a review session on Monday. I'll get the cases posted hopefully tonight or tomorrow, and I'll see you guys for the review Monday.